Welcome to Capital Connections. I'm your host, John O'Connor. We're coming to you from the H. Raymond Danforth Library on the campus of New England College. Did you know opioid-related emergency department visits in New York increased 73% from 2010 to 2014? For the next 3 weeks, we'll continue our focus on our attention of the opioid crisis and mental illness in Vermont, New Hampshire, and northern New York. Our mental health can be compromised by so many things, like sudden loss, complex trauma, chronic illness, co-occurring disorders, and more. Without proper diagnosis and treatment, people often self-medicate and begin a dangerous cycle that adds more challenges to their lives and the lives of others. Recently, New England College hosted a panel on mental health and the opioid crisis at their Concord, New Hampshire Center. The panelists included John Broderick, the former Chief Justice of the New Hampshire Supreme Court, Dr. Paul Dan, Program Director of the New England College Master's Degree Program in Clinical Mental Health Counseling, and the Executive Director of NFI North, a multi-service behavioral health organization. Peter Evers, the CEO of Riverbend Community Health Center, and attorney Michelle Merritt, Policy Director of New Futures, an organization that works to prevent and reduce substance abuse problems. The panel was moderated by Scott Spradling, an Emmy Award-winning media leader and consultant. We'll hear from Peter, Paul, and Michelle about their organizations and their efforts to address the related problems of mental illness and addiction. But first, these words from the good businesses that believe a well-informed community is the greatest strength in sustaining a strong democracy. Welcome back to Capital Connections. For the next 2 weeks, we'll continue our look at the opioid crisis in Vermont, New Hampshire, and northern New York, and the related mental health issues. Today, John Broderick, Peter Evers, Paul Dan, and Michelle Merritt will take questions from the audience. Let's join Scott Spradling, who moderated this panel and presented the questions.
Michelle and Peter, you just talked about one of the boxes that we can check in terms of hurdles to the kind of help that we need to provide, prior authorization. What are some of the other big hurdles that still exist right now that we need to be focusing on as part of our to-do list?
Do you want to take this one first?
Sure.
I have a large list.
Yeah. Well, you know, I was thinking about this, and I was in a meeting this morning, and you know, there are people that provide treatment. There's Michelle, and by the way, if you've ever seen Michelle in action, legislators don't have a chance when she gets her teeth into an idea like this. You've got academia, and you've got policymakers, and they all play a role in making sure that we get the services that we need to people. But we have, I think, a responsibility to be able to show that what we do works. And we do that by telling those stories, because those stories actually, I mean, it is remarkable if we bring people in front of policymakers and allow them to tell their stories. But more than that, we need to show empirically with data that the work that we do as a system is effective. There's $750 billion of waste in the healthcare system in America. We spend 18% of our gross domestic product on healthcare, and much of it is wasteful. We need to show that when we work together and we work towards outcomes that make people better instead of just churning out encounters of care, not only do we persuade people that the human face of addiction and behavioral health is getting better, but we can show that in an economy which is stretched, our product is a valuable and quality proposition for this country.
Thank you. Give us the thumbnail sketch, Michelle.
So I think my perspective is a little biased based on what I'm concerned about for this upcoming session. New Futures has a 5-point agenda that we think will significantly change and help to combat our state's opiate crisis. It consists of a number of things. Just going to give them high level and then get into a couple of them. The first is to make our state Medicaid expansion program permanent. I'm not sure how many of you here are familiar with our Medicaid expansion program. It's also called the New Hampshire Health Protection Program. And just high level, we need to remove the sunset provisions within that bill for a number of reasons. First, it's the single most important tool we have in our toolbox to combat our state opiate epidemic. We've doubled our treatment capacity through Medicaid expansion for people with substance use disorder. We had been 49th in the country for people who needed treatment being able to access it. Only 6% of people actually could get treatment when they were asking for it, which is a travesty in my opinion. There was a survey done by the New Hampshire Alcohol and Other Drug Service Providers Association around expanding treatment capacity. It's a theme that we've sort of already been discussing, that we don't have a sufficient workforce to meet the demand. Even though New Hampshire Health Protection Program has helped to expand it somewhat, we need to do more. And when these providers were surveyed and asked, what is holding you back from expanding your treatment capacity? One of the primary things was, well, we can't invest in bricks and mortar expansion of our facilities because we don't know if this program is going to be around in 2 years. And I don't know any business person that would say that's a great investment. Let's put all of our eggs in this basket. 80% of the people that we serve are on Medicaid expansion, and it might not be there in 2 years. So that's one. Second is fully funding our state alcohol fund. You may know, or you may have seen in the newspaper recently, New Hampshire actually has a fund designated to support prevention, treatment, and recovery for individuals with substance use disorder. It's supposed to be 5% of our gross liquor profits, but almost every year the state has suspended that formula and put it in general funds. It's been chronically underfunded. So we need to fully fund that fund. We need to invest in evidence-based prevention programming. We need to support workforce development. And then when you get into insurance barriers, which is the last point, we have many people now, thankfully, through New Hampshire Health Protection Program and other now access to insurance coverage for substance use disorder and mental illness who are in recovery. And many of them can't access the recovery support services that they need. There's no reimbursement within insurance companies for a lot of those services. We also have issues where people might be in recovery from a substance use disorder that's opiate based, and they are in acute pain as a result of an injury, and there's no method for them to get a non-opiate prescription because the tier in the formulary is such that it's cost prohibitive. So these people have two choices: either you suffer with your acute pain or you take an opiate and potentially put yourself at risk for a relapse. It's horrible. I don't think we should put anyone in our state who's gone through the treatment program and is successfully in recovery in that situation. So those are the things that I think that we could potentially work on, but that's my high-level spiel.
That's good. That's good spiel. Thank you, Michelle.
Did you know that the number of prescriptions written for opioids quadrupled between 1999 and 2010? In 2012, for example, 259 million opioid prescriptions were written, enough to put one bottle of pills in the hands of every adult in America. When Capital Connections returns, we're going to hear more from our panel, so please stay with us. Welcome to Capital Connections. I'm your host, John O'Connor. You're watching a panel discussion on mental health and addiction from New England College. Let's again join the moderator, Scott Spradlin.
But I want to bring in Paul because two of your items still really revolved around this concept of trying to get enough trained people up and ready to handle the load, if you will. Can you shed some more light on what the NEC program looks like, how it's being structured, and what the results will be as you're producing graduates in Henniker and here in Concord?
Absolutely. Thanks, Scott. And thanks for that view of policy, because I think all of those things are critical, and we're going to have to tackle those things in order to make a difference in the situation that we're facing. As I mentioned earlier, I alluded to earlier, one of the things that we did at New England College was we got together and we said we have this robust, rich clinical mental health counseling program that's been operating now for probably 20 years. What can we do to step up to make a difference? And we realize that there's some critical partners here in the state that we probably should reach out to begin a dialogue around how we can help impact the need for trained clinicians to come through an academic program and work effectively within our state system. So what we did was we got together with people like Peter and some of the other CEOs from the community mental health centers, and we said, we have an idea about how we can advance the training for your employees who can become our students, and do it in a way that's going to give them theory-rich, practice-rich experience around how to become an academic training around how to become a clinical mental health counselor. And so this was an initiative that we stepped into this past spring, and I'm very pleased to report that it continues to grow, and that in fact probably we're looking at within the next 20 months graduating somewhere close to 40 clinical mental health counselors through the program. So we're working hard to make a significant difference. We're also recognizing that things don't live in the silos, that things don't exist honestly in silos, that they cross the boundaries, and so as a result we're moving forward with an addictions curriculum in order to help build the Masters in LADAC, Licensed Alcohol and Drug Treatment capabilities here in the state. So we're taking some active steps to do that, and one of the things that we've just been incredibly impressed with is how receptive really everyone is when we say, look, we have some ideas, we have some solutions. And I guess that's one takeaway for me as well, which is in this room there are so many ideas, and through that potential solutions. And I think, as Michelle's saying, if you get your story and you can get out there and share with people, one of the things that's beautiful about New Hampshire is we're small enough that we can make a huge impact, any one of us. Mm-hmm. So I think that's good news for us as well. So that's one of the things that we're doing, Scott.
Thank you. Peter, there's another Peter here in the room, a friend of mine from the Farnham Center, Peter Burke, who's sitting back there. And the Farnham Center, for those of you who may not know, have a location in Manchester and in Franklin, and they treat substance abuse, alcohol abuse. They have a wonderful health realization-based program that is proving to be very successful. And it raises the question because the point has sort of been indirectly made now multiple times. And I believe, Peter, it was you that gave me the stat of 65% of those facing substance abuse issues right now and challenges have co-occurring mental health challenges. So what are the impacts of that statistic, and what might the opportunities be, given that we are at least right now as a state citing opioid addiction as a #1 issue, and that there's a march for change on that, and yet there's so much co-occurrence?
Right. So, sort of, I suppose I would start by saying, go back 20 years or so, and somebody would come into treatment in a place like Riverbend or anywhere else in the country and say, I'm very depressed. And they would say, well, are you drinking alcohol? Are you using any drugs? Yes, I am. And the intake person might say, you know what, get yourself sober, right? And then come back and we'll begin treatment. And that really was the way that we looked at these two diseases, that, you couldn't treat them both together. John mentioned once that the psychologist in the prison had said that Christian was drinking because it was taking away some of the negative feelings that he had. And in fact, that isn't a good decision, but it's actually a logical joining the dots decision. If I feel psychic pain, if I feel dread and hopelessness and all of those 5 signs, and I can get out of that and I can alter my mind state for a minute, I'm going to do that. I pay the price 5, 6, 7 hours later when I come out of that and I'm even more depressed, but I'll buy those hours. So to begin to say that we shouldn't be treating these people who present like that at the same time, it was wrong. And so along came an evidence-based practice, which is this sort of co-occurring disorder treatment. Because when you look at the diseases, they have very similar tracks within treatment and recovery. And we need to be able to do that and come together and share those thoughts. And I think we need to do it earlier on. Somebody once said that, instead of fishing people out of the river, we should actually be walking up the hill from the river and see who's throwing those people in. Well, childhood trauma is a great indicator of problems later on. Oftentimes, school teachers in preschool can identify children who are going to have trouble graduating. And another statistic that John uses is that and I can't exactly remember it, but by age 14, is it
half of all mental illness?
Half of all mental illnesses is occurring. So prevention is such a huge part of that. Treating these things together is such a huge part of that, and making sure that the resources are available for that. We have in this state 250 MLADACs, that's the master's level licensed alcohol drug counselor. Well, that's ridiculous. We need to do something about it, and it is these partnerships with academia and where treatment is happening and recovery is happening that we can really begin to build the stock of those people who can provide those services.
Are there any locations, be it a state, a country, a city, a private nonprofit agency, that is showing us the way in how to bring this type of treatment together under one umbrella?
Well, there is a state slightly to the south of us that I can't name. But if you look at Massachusetts system, and it's not perfect, it really isn't, but it has a sort of payer of last resort, which is the Department of Public Health for addiction, and the Department of Mental Health, and they're not adequately funded. You might have read in the Boston Globe recently there was a investigation into the state hospitals, but what they did years and years ago is they said, look, these illnesses need to be combined and they need to be treated, and they need to be provided for anybody who turns up. I had the privilege of being the director of a detox in Boston for 3 years. In some ways it was the longest period of my life. In other ways it was the most learning experience I ever had. And it became very obvious that when we took those people into the detox, we weren't providing any of those services. And we said, well, why don't we bring psychiatrists and social workers into this residential setting, begin treatment as people are coming out of their addiction and withdrawing, because that's when they need it most. Decriminalization is this other issue, which I think we should get to.
Yes.
But, they say we can't arrest ourselves out of this problem. We've arrested ourselves into this problem. So we need to be able to say that this is not a criminal matter, this is a disease that needs treatment. And when we begin to do that, we begin to address this issue that we are 5% of the world's population. We have 25% of the world's imprisoned. In the whole, 25% of that population are in American jails. 80% of those people struggle with a behavioral health disorder, and 20% of those people are in jail because of their addiction.
In a 2013 study from the Substance Abuse and Mental Health Services Administration, it was revealed that 4 in 5 persons in the U.S. who started using heroin also reported first using prescription opioids for non-medical purposes. When we come back, you'll hear more questions from the audience to our panelists. Please stay with us on Capital Connections. Welcome back to Capital Connections. I'm your host, John O'Connor. Over the course of 4 weeks, we're looking at obstacles before our states in providing good mental health and addiction services. Let's now join Scott Spradling, our moderator, for the next question.
Many of you have written some questions, some really good ones, and the first one I'm going to ask is about the prison system in a second, but I want Michelle to go first.
Yeah, the only thing that I wanted to add was, and we have this experience now, and Peter can attest to this because we're now working as a state to try to integrate care, not just behavioral health care, the mental health and the substance use disorder, but the whole health, to stop, I know there's a phrase, taking the head off the body. There were times within the last 10 years where health insurance plans were carving out any type of mental health or substance use disorder treatments from their plans, and providers that were doing the same. New Hampshire is making some great strides to integrate care. So I didn't know, Peter, if you might be able to talk a little bit about the IDN work that's going on, because I know you're an active participant in that in the Concord area, and how valuable it is to treat the whole person in addition to the mental and substance use disorder.
Sure. New Hampshire was the recipient of what they call, of course, this sounds so federal government, an 1115 waiver. It's just so...
Hey, congratulations.
I remember when it came. It was awesome.
Yeah, it was. Why don't they give it some other name? But
Seems like just yesterday it was 1110.
but what that meant was $150 million of federal money came through the state of New Hampshire, and the Fed said to us, we're going to give you this money, but we're not. But with it, you have to be transformational. You have to think about doing things differently. And we decided as a state that we wanted to put those resources towards the integration of care, so that any door that you go into, you are going to get the services that you need. And we've taken on these community projects, such as reentry. You know, the state of New Hampshire is a state that cuts people's Medicaid off when they go into jail rather than suspending it. That's a real problem for people coming out, because they're coming out of jail where they haven't had appropriate treatment back into communities, and they're not able to get into treatment immediately because they have to wait for Medicaid. We're also providing enhanced care management. It's the old 80-20 rule. You know, there are people who really struggle with these diseases, and they take up a lot of resources because we're not working together to provide those services. Mm-hmm. And so this is really, over the next 5 years, this is going to give us the ability to do things beyond Medicaid codes that look transformational to us, so that we can keep people out of emergency rooms, that we can keep people out of the state hospital, we can keep people in their communities where they can work and live and love and do all the things that we need to do as human beings.
If you need help, there are places you can turn. In Vermont, go to the website healthvermont.gov and click on Substance Abuse Programs. You'll find information on prevention, treatment, and recovery services associated with their community partners. When we return, I'll give you more information on how you can help someone or even yourself, so please stay with us. If you're watching our show and need help, there are places you can turn. In New York, go to the website of the Office of Alcoholism and Substance Abuse Services. In our next show, we'll conclude the panel discussion as they answer more questions from the audience. So please join us at the same time next week for another edition of Capital Connections, your weekly access to politics and policy in Northern New York, Vermont, and New Hampshire.